Thank you, Dr. Abdulrahman, for this kind introduction. And I hope you guys are awake after this delicious lunch that you had. So it's a big topic because there are so many cardiovascular diseases. So I'm going to try to focus on the most common ones and try to give you some tips of how fasting can affect cardiac conditions. So basically, we're going to identify cardiac patients with high risks of fasting. We're going to understand the impact of Ramadan fasting on cardiovascular diseases and how to manage common cardiac diseases during fasting. So worldwide, there is approximately 1.8 billion Muslims. Around 3.4 million of them live in the UK. 93% of them are likely to observe Ramadan fasting. And of course, in this part of the world, almost 100% will observe Ramadan fasting. So that's why this becomes a very important topic. And fasting is associated with a change in the rhythm and quality of food, as well as the circadian rhythm, with a shorter nocturnal sleep period. So I'm sure we all been through this during Ramadan. You sleep less, you eat more, the time that you eat is different, and that leads to physiological changes that we not always are aware of. And there are several metabolic changes that occurs during the fasting month. All these changes have an impact on the pharmacology of certain medications, especially antiplatelets, antihypertensive, and heart failure therapy. So let's start with the most common one of them, hypertension. Hypertension is by far the most common disease worldwide. It affects around 40% of people, but that reaches to about half of the population in Muslim countries. So half of the people who are fasting are hypertensive. So we need to know how to manage hypertension during Ramadan. Blood pressure may be influenced during Ramadan because of many factors, including mainly alteration of eating patterns, sleep pattern, and the timing of taking their medications. So this is a summary of all the studies that looked at the impact of fasting on hypertension. And I don't expect you to read all of that, but I will tell you that the things in yellow are the ones that showed no significant difference, whether you're fasting or not, on the control of blood pressure or the complications of hypertension. Now, the ones in green shows that there was significant reduction in blood pressure. So there was significant reduction from baseline in systolic blood pressure or diastolic blood pressure or the pulse pressure in these basically 3 studies. So there's some differences, and the differences usually, you're going to see the similar pattern in other group of studies. It's because of the dietary patterns. So diet has significant effect on all of cardiovascular conditions, and it also has significant effect on your hemodynamics during Ramadan. So generally, adherence to a salt-free diet and drug intake are impaired during the month of Ramadan. And this what leads to some of the changes that we see in these studies. But luckily, in literature review, there is no recorded incidence of increased hypertensive crisis during Ramadan. So we don't expect that to cause major adverse cardiac events, and no statistically significant difference in general in the recording of blood pressure. Also, fasting may have some protective effect because hunger is associated with catecholamine inhibition and venous return reduction, which causes reduction in sympathetic tone and a fall in blood pressure, heart rate, and cardiac output. So the variation of blood pressure are minimal, and it's really related to diet, sleep patterns, and eating patterns. And in a study by Council, they found that the heart rate during Ramadan is usually lower than the heart rate during the regular months, which is an effect of the parasympathetic system. So generally, fasting is better for your blood pressure. So it's usually safe with moderate severe hypertension patients treated with combination therapy. So what would be the recommendation to be given to a patient? So if they're uncontrolled or have malignant hypertension or secondary hypertension, it's better not to fast. especially if the secondary hypertension, the etiology is not known, so you're supposed to know what the etiology is and do the investigation before that. So you need at least a month before Ramadan to figure these out, and then you can let the patient fast. Of course, I'm sure like lots of you deal with hypertensive patients all through the year, and we all have very uncontrolled patients, and all of them fast, and none of them have any problems. So, I mean, at the end, recommendations come because they try to extrapolate from whatever evidence there is. But most likely for hypertension, it's not going to be a major problem for the patient to fast. So if the patient is severely hypertensive, but it's controlled, there's no major issues. But you have to tell the patient to adhere to both non-pharmacological and pharmacological measures. So adherence to medication, low salt intake is very important even during Ramadan. So they should have low salt diet, low fat diet, and you try to avoid diuretics as a therapy. Of course, if you have someone who's severely hypertensive, uncontrolled, you have no choice but to use diuretic therapy, but try to change the timing of the diuretic therapy so it's not at the time of breaking fast. And of course, try as much as possible to use once daily medications and combination therapies, because then they're easier to be administered in a different timing of the day. And if there is hypertensive emergencies, it has to be treated appropriately regardless if they're fasting or not. So now let's move to heart failure. So these are the studies that looked at the impact of chronic heart failures in patients who are fasting. No significant difference. And actually, we see this in our practice. We actually see less heart failure admissions during Ramadan. And we don't see that the patients worsen during Ramadan. Of course, these studies looked at patients who are chronic stable heart failure. So these are not the ones who were recently admitted. These are not the ones who are class 4 heart failure, so they are short of breath at rest. These patients should be advised not to fast because there's significant change in their hemodynamic, and you require some time for the medications to be stable before they can fast. So that, of course, becomes a very difficult discussion, especially in this part of the world, because everybody wants to fast, and heart failure is a disease of the elderly. So they're in their 70s and their 80s, and you're asking the patient not to fast. It becomes a really challenging discussion, but at the end, it's a discussion. So, as a physician, we never tell the patient, do this or else, We tell them this is the best for you. Then you're going to hear back from the patient. We prepare them ahead of time. So usually this discussion starts at least a month before Ramadan. We see them every 2 weeks. And we discuss like their kidney function, their salt intake, their water intake. But the good news is if you have a stable patient, they can fast. There's no issues. So this is in a prospective study that looked at 247 patients with chronic heart failure and reduced ejection fraction. They had actually improvement in the NIHA class during Ramadan with 91% of patients. And the only predictor for decompensation in heart failure was non-adherent to drugs and diet. So if they were not adherent to drugs and diet, then they're going to decompensate. But if they're compliant, they're going to cruise through Ramadan with no issues. So the recommendation for heart failure is, so patients with decompensated heart failure or severe systolic dysfunction are not allowed to fast, especially if Ramadan falls in summer. And then you have to be careful with the medication. So of course, SGLT2 inhibitors is one of the cornerstone medications for heart failure. So usually you should aim to initiate it ahead of time before Ramadan. So at least a month before Ramadan, the patient has to be stable on his medication and the dose. And you might choose to either increase their fluid intake during Ramadan and encourage them to drink more water from sunset to sunrise, or you reduce the dose of their diuretics, depending on the patient condition. And of course, reducing the dose of diuretic regardless of the other medication is also another thing that you have to consider. So the management of heart failure in Ramadan is a little bit different. It's not going to be the same for every patient and the other, because one patient would have just heart failure and no other comorbidities, and the other patient will have heart failure, renal impairment, diabetes, hypertension, and then it becomes a little bit more complicated in terms of how to manage their fluid status and their medication. So now let's move to coronary artery disease. So coronary artery disease, these are all the studies that looked at how fasting will affect coronary artery disease. And in yellow, all the studies that showed that there was no significant difference in the admissions of MI and the recurrence of angina in patients who are fasting or not. Now, these two studies that found difference actually were contradicting each other. So this, I think the marker doesn't. So the first one in green, Al Suwaidi, they found that patients with who were not fasting, the patients who were fasting had higher numbers of acute MIs. The second study, Turker, showed higher number of acute MIs in patients who are not fasting. So basically, they're canceling each other. But there was a difference in the timing where MI happens. So, the common teaching is MI happens early morning. I mean, it can happen any time of the day, but generally very early morning, between 5 and 6 o'clock in the morning. But in Ramadan, MIs happen at night rather than in the early morning area, between the hours of 9 and between the hours of 6 p.m. and 12 p.m. And the reason for that was thought is because of the whole hemodynamic changes that happen. There's changes in the cortisol secretions as well in the body. So instead of having your peak cortisol early morning, you're having your peak cortisol at night. So that's the reason why the timing of MI is different. So, but looking really at why would cardiovascular disease happen differently, it actually is found to be protective studies that looking at pathophysiology. So this study by Yusufi looked at endothelial function during Ramadan in 21 patients. So it's a small study, but it's really looking at pathophysiology. And they found that nitric oxide was higher in patients in Ramadan compared to the baseline. And nitric oxide is very good for the heart because it dilates the coronaries. So you're less likely to have cardiovascular disease if you have a higher nitric oxide. This other prospective study looked at serum amyloid A and protein carbonyl group, which are both markers of cardiovascular disease. And they found that these two proteins are actually significantly lower during Ramadan. So fasting does have some cardioprotective effect. It's just that when you see the studies that showed no difference, they're looking at acute MI. So maybe we should look at more markers and more, rather than who had an acute MI during Ramadan, who will have recurrent events if they continue to fast or not. So it's all, hypothesis provoking. So what should you recommend for your patients with CAD? Generally, patients with coronary disease can fast, but those with unstable coronary disease are encouraged not to fast. So these are very rare patients, the ones that generally just had an MI and you're worried about their systolic function, or patients who had recurrent angina that is not controlled. But other than this, all patients with CAD can fast. You should advise them to take the aspirin during a meal, and you should make sure that if they have gastric disorders, to have a PPI prescribed. There has been a recent study that found that fasting alters cytochrome P450 mediated drug metabolism, and I'm not sure if you know that, but clopidogrel is mediated by cytochrome P450. So there might be an effect on clopidogrel, but this has not been translated to something clinical yet. So this is something to look for. Like everything else, you should aim for once a day medication or twice a day medication. So if the patient is in the medication that's given 3 times a day, like nitrates, for example, then you can change them to a sustained release medication for better compliance and to avoid postural drops in blood pressure. Now, how about patients who are on anticoagulation? Just using anticoagulation during Ramadan make a difference. So these two older studies showed no difference, and then the two most recent studies, actually there should be another green down there, showed a difference, and actually a significant difference in INR during Ramadan. So, and we all understand warfarin is related to diet. So if you change your diet, your INR will change. So that's expected. Also, vitamin K antagonist is displaced from serum albumin by free fatty acids. So if you're eating lots of samosas, food that is high in fat and carbohydrate, then you're going to displace more of vitamin K, then you're going to have a higher INR. And also fatty acid and serum albumin ratio may increase by up to 6-fold during fasting. So the affinity of serum albumin to vitamin K antagonists would be reduced. With increased plasma concentration, you will get a higher effect of vitamin K agonists. And also there is the hypothesis that patients who've been treated with vitamin K antagonists for a very long time, they have a sensitivity to the dietary vitamin K intake. So even a smaller amount of increase in vitamin K intake during Ramadan will potentiate the effect. So what would be the advice for patients for anticoagulation during Ramadan? You need to check their INR before Ramadan, and then frequently monitor patients who usually have labile INR or high INR by preemptive titration during the period of fasting. And you should always remind the patients about the risk of food interactions. They cannot take a vacation during Ramadan and eat whatever everybody else is eating. They have to take the same precautions that you would take with taking warfarin. Now, in the last few minutes, I'm going to talk a little bit about the less common cardiac problems. So what about arrhythmias? So, I mean, generally, like as cardiologists, we don't pay a lot of attention to this because there isn't a lot we can do about this. But it has been reported that asymptomatic premature ventricular complexes are more frequent during Ramadan. But they're asymptomatic, and usually we do not intervene on this. The ASC 2020 sport cardiology guidelines suggest that patients with long QT should avoid dehydration because it can predispose them to arrhythmias. So this is specifically for patients with long QT. The AHA guidelines states that sleep cycle and eating disturbance, which is common in Ramadan, can lead to increased incidence of atrial fibrillation. So this is, I wouldn't say this is supported by a lot of studies, and it's not a reason to stop fasting if you have atrial fibrillation. But it's something that was mentioned. So maybe we actually need our own studies to look into that because, again, we're talking about a population here who 100% fast Ramadan, whereas you're talking about an American population which have smaller number of people fasting in Ramadan. And then there's an issue of anticoagulation. I mean, it's a very busy part of the slide. But actually, this is a very important survey that was done during fasting for patients with atrial fibrillation who have an indication for anticoagulation. And they noticed that half of the patients modified their anticoagulation during Ramadan. And this is a very dangerous thing because then it will lead to complications. So if they're taking NOACs that are taking twice a day, then they're likely to skip one dose. If they're taking warfarin, they're likely to take it with the food, then that interacts with the mechanism of action. So this is very important. We need to address compliance in the patient. Other cardiac conditions. So hypertrophic cardiomyopathy is an important one. So if you have a hypertrophic cardiomyopathy patient with severe obstruction, they should not be fasting because hypertrophic cardiomyopathy is a volume-dependent problem. So if the patient is dehydrated, they're more likely to get obstruction, and they're more likely to get syncope. Now, patients with adult congenital heart disease, depends on what type of adult congenital disease they have, might be advised to avoid dehydration. So especially if they're cyanotic congenital heart disease. And also patients with orthostatic hypotension and postural orthostatic tachycardia also are advised to avoid dehydration. So depending on the patient, you might ask them to not to fast during Ramadan. So this is a proposed algorithm on how to approach a cardiac patient for the assessment of their feasibility to fast in Ramadan or not. So first of all, you establish the patient's background. You see if they fasted before. If they have fasted before, what was their experience? Because if they have all these things that I told you, for instance, I just told you that hypertrophic cardiomyopathy with severe obstruction should not fast. I have a patient who have hypertrophic cardiomyopathy, severe obstruction, who has been fasting for the past 5 years with no issues. So he's going to continue fasting. There are a lot of the advice that we give it because we're trying to protect the patient, but there are lots of factors that go into it, including how much hydration they will do, how much salt they will eat, and some of these factors they can control themselves. So if you know the patient can control these factors, then you have no major issues. So you check how if they fasted before and how did it go with them. You check their symptom status, smoking status, what's exactly their cardiac issues, and what's their medications and how compliant they are. And then you review the recent investigation, make sure the most important thing, of course, is creatinine and urea electrolyte, but also check their echo, check if they have devices, and try to do a risk stratification and communicate that to the patient. They have to understand why it is dangerous for them to fast. So you talk about their kidney function, you talk about the risk of arrhythmias, you talk about the risk of volume overload, and then you give them advice on the healthy diet and fluid intake during Ramadan, and you give them advice on when to terminate fasting, because let's say the patient insists that they're going to fast. You tell them, well, if you're dizzy, you have to stop fasting. If you're feeling unwell, you have to stop fasting. You have to come back to do blood tests, and we have to see you. And post-Ramadan, you review them and make sure that the symptoms didn't change, and make sure that they go back to their usual therapy. So this is like a recent consensus statement on the different risks of cardiac diseases and which ones are considered moderate risk, which one are high risk, and which one is very high risk. And really the patients who must not fast, regardless of the condition, is advanced heart failure and severe pulmonary hypertension patients. Other patients will fall in either the category of moderate to low risk or the high risk. So high risk patients, according to this consensus, so this consensus was published in the BMG, and they said, well, should not fast. But really, like if you look at this, all of them do not have, like they would not apply to our population. So let me tell you. So if you look at the ones who do not fast, poorly controlled hypertension, yes, but I mean, a lot of them manage, but poorly controlled hypertension, you should give the patient an education a month before and tell them, you have to be compliant with therapy. Recent acute coronary syndrome within 6 weeks. I mean, acute coronary syndrome for a cardiologist, I mean, different acute coronary syndromes are different. Someone comes in with chest pain, new onset chest pain, you did a PCI, he's completely revascularized. There is no reason for this patient not to fast for 6 weeks. They can fast next day. But if you have someone who had a massive anterior MI and their ejection fraction dropped to 30, and they're now on a lot of medication, then probably that patient will wait for 6 weeks. So this is not a must. That's why actually they put it in yellow, but they did not understand how important fasting is for us. So they said should not fast. Hypertrophic cardiomyopathy with obstruction, again, it's a condition that's volume related, so should not fast, but there are precautions. Severe valvular disease depends, again, because obstruction gets worse with dehydration, but it depends on the patient, it depends on what their blood pressure is, because with dehydration, you're going to drop your blood pressure. So if someone have a blood pressure of 140 and they're going to fast, their blood pressure is going to go to 120, they're going to be fine. So there's not going to be a major issue there. Severe heart failure without advanced features. So that, what we mean by that is ejection fraction less than 30, but otherwise the patient is like class 3, NIHA class 3. So he's not short of breath at rest, but he's not short of breath at minimal exertion. Again, it's a very borderline, let's say, indication not to fast. Because if you have a patient who's really dedicated, he really wants to fast, he has no renal impairment, you can manage their medication, you can ask them to check blood tests during Ramadan, they will go through Ramadan with no problems. Poorly controlled arrhythmias, again, as we said, like AFib is more likely to be worse during Ramadan, but can be controlled by medication. So really, it is depending on the type of arrhythmia, so you should refer to the electrophysiologist. High risk of fatal arrhythmias, so they're talking about inherited cardiac arrhythmia issues, so again, go back to the electrophysiologist. And patients with ICD and cardiac resynchronization devices, so that again is not an indication not to fast, it's just, that just tells you how consensus is different from one country to another. You know, they put it there just because patients with ICD and CRTs are usually advanced heart failure patients. So that goes with the severe heart failure without advanced features. But again, that doesn't mean that this patient should not fast. So, and this is an algorithm, I think we're close to be running out of time, but this is an algorithm, what you should do. So, and they say that if the patient is high risk or very high risk, you should recommend them not to fast. But then if they choose to fast, what you should do, because they understand how important this month is to all of us, you know. So then you give them alternatives. So you tell them, okay, maybe try to do non-consecutive fasting. So fast one day and don't fast the other one. Or maybe try to fast in Shawwal before. So try a couple of days before Ramadan and see how you're doing, and then fast again in Ramadan. And then, of course, have frequent checks for the patient, make sure they comply with medication and diet restrictions, and have frequent follow-ups. So these are the most recent recommendations. This is a recommendation for cardiovascular patients, the one on the top. This was published in 2022 in BMG. And the other one, cardiovascular disease and Ramadan, a literature review. This was published again in January 2022. So these two articles are very important to read because they summarize all the evidence that there is in managing patients with cardiovascular disease in Ramadan. And you have 2 minutes for questions. Thank you very much.